What, tonight? Yeah. Sort of toying. I'm gonna go a little bit. And then yeah. Thank you.
So we're going to get things started. We've got some stragglers coming, but out of respect for our online folks, we're going to get started. Are we live? Yeah, okay. Great. All right. Hello again, everyone. My name is Gwen Driscoll. I am the Director of Communications here at the UCLA Center for Health Policy Research. It's my pleasure to welcome you to our second to last seminar of the 2016 Health Policy Seminar Series. And speaking of our last seminar of the year, just a little bit of advanced promotion, in December, and specifically on December 14th, we have exciting news for those of you who have been patiently waiting for it. We will release 2015 data from the California Health Interview Survey, and to orient us to all the new and updated variables, including important indicators of health insurance status, chronic conditions, psychological distress, e-cigarette usage, and much more, the director of CHIS, Todd Hughes, as well as today's speaker and CHIS principal investigator, Dr. Ninez Ponce, will host a noon seminar. Again, that is Wednesday, December 14th from noon to 1 p.m., so please join us. Oops. There it is. Save the date. Okay. Yeah. You can't hear? Okay, I'll try and speak a little louder. Yeah. Okay. So as for today's seminar, we will be recording it, and it will be placed on our website at the address you see at the top of this slide. If you would like copies of today's presentation slides emailed to you, please email me at gdriscoll@ucla.edu. And of course, if you would like to stay up to date with all of the center's latest research, data, and seminars, please subscribe and tell your friends to subscribe to our popular monthly e-newsletter, Health Policy News, and that's the link that you see at the bottom of this screen. Please note also that we will have a brief question and answer period at the end of today's seminar that I will moderate. Okay. Now, without further ado, it is my pleasure to introduce today's speaker and the Center's Associate Director, Ninez Ponce. Ninez is a professor at the UCLA Fielding School of Public Health and a nationally known expert on racial and ethnic health disparities. She is also the principal investigator for the California Health Interview Survey, and as such leads ongoing efforts to collect essential data that helps policymakers, advocates, the media, and many others address and identify the health challenges of California's communities of color. Drawing upon comprehensive research conducted by center researchers Ying Meng and Vanessa Lam for the Landscape of Opportunity, a recently released report by the California Pan-Ethnic Health Network, Ninez will talk today about how access to affordable housing, jobs, doctors, and quality health care, as well as insurance, safe neighborhoods and parks, and so much more, varies depending on the color of your skin or your cultural community. Given the recent election results, I think there are many of us in this room and online who feel that health disparities and inequity in general have become a critical issue for the future of our nation. As such, Ninez's presentation could not be more timely. Please welcome Dr. Ninez Ponce.
Thanks so much, Gwen. Hello, everybody here, and those who are joining us online, and I hope you all had a joyful Thanksgiving. So this presentation today is based on a report, and I'll have you can see this in the camera, by the California Pan-Ethnic Health Network. It's the Landscape of Opportunity. It's actually the third edition. Previously, in 2009, there was a version, and in 2012. I'd like to acknowledge that the main authors are Sarah DeGia and Carrie Sanders from California Pan-Ethnic Health Network, and from the UCLA Center for Health Policy Research side, Dr. Ying Meng and Vanessa Lam, who is here actually in the audience today. I wanted to talk a bit about CPEN. CPEN is one of our long-standing partners at the Center for Health Policy Research, and certainly with my work. They provide publications that provides in-depth analysis of the most pressing multicultural health policy issues in California. They were founded in 1992 by leaders from 4 ethnic health organizations: the Asian Pacific Islander American Health Forum, the California Black Health Network, the California Rural Indian Health Board, and the Latino Coalition for a Healthy California. So my disclosures here are, I'm a presenter and not a producer of the work, so I feel like I'm doing a cover, like I'm doing like Leonard Cohen's cover. So I am a presenter of this. I certainly hope to be an amplifier of this work because I think this work is very, very important. I do disclose that one reason why I'm a big fan is that I'm a former board director of the California Pan-Ethnic Health Network. And hello, Ying, we were just joined by one of the study producers, Dr. Ying Meng, in the room. I'm also a former staff of the Asian Pacific Islander American Health Forum, which is one of the ethnic organizations under CPEN. And lastly, the main data that's used in this report is the California Health Interview Survey. I am the principal investigator, so although, again, I'm doing a cover, it is using the data that we've spent a lot of time, the CHIS team here have worked on and certainly have promulgated, and so delighted that organizations like CPEN are using this. Okay, so today, there's 4 parts of this story. There's the framing, the evidence, what I'm calling the fix, and then ending with the data and summary. So the framing. Let's start first with some definitions. Health disparities. Health disparities, health and healthcare disparities, refer to differences in health and also differences in health care between population groups. Disparities occur across many dimensions, including race, ethnicity, socioeconomic status, that's income, education, occupation, age, where you live, location, your gender, the disability status, and sexual orientation. There are other more specific definitions of health disparities, for example, in unequal treatment, an Institute of Medicine report that distinguish that a difference is not a disparity. You could have a difference, say, in the number of doctor visits for a black versus a white individual, but if these differences are allowable if it's based on need and preferences, but they are not allowable if it's based on some systematic injustices that occur that undergird these differences. So this is a health disparity. Health inequities, which I think more is coming in the vernacular in public health, are differences in health that are not only unnecessary and avoidable, but are unfair and unjust. So health inequities are rooted in social injustices that make some population groups more vulnerable to poor health than other groups. This particular definition is from the World Health Organization. Increasingly, particularly in a diverse state like California, the notion of intersectionality is important as a frame. An intersectional lens in policy focuses on viewing inequities experienced by race, gender, class, sexuality, and other vulnerabilities, or what I call social penalties, in tandem with each other rather than distinctly. And health equity is then the absence of structural inequalities that drive disparities in health between groups with different levels of social advantage and disadvantage. So as each definition brings in new terminology that requires elaboration. So let's continue. What are these structural inequalities? Well, before we go there, the social determinants of health, I think, it also requires some definitional beginnings. The social determinants of health are the conditions in which people are born, grow, live, and age. And these circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. So this is really important because I think this frames the rest of this report on why the analysis frames are looking at different places in California. Okay. And this framework of social determinants of health, again, this is from WHO, shows that these structural inequities that I had mentioned from Paula Braven's definition are huge. They loom large in the constellation of determinants that lead to health and well-being. So much so that these structural inequities, which largely are produced by decision makers, their policies, their macroeconomic policies, wage laws, public policies in education, in health and social protection, and culture and social values, that these structural determinants of health loom large when you compare it to what we see here, the health system. So that the inequities that we see in health are not just a product of what's going on in our health system. Its health system is an important part, but there's other contextual factors that need to be considered. So in this multicultural framework for health equity, where socioeconomic factors of education, jobs, and income, environmental and social factors, the natural and built environment, neighborhood safety and cohesion, criminal justice and healthcare, all are influenced by race, ethnicity, culture, and language. As multi-identity, multicultural individuals and communities, we encounter systems differently in ways that either support or hinder our health. It's important to know that certain systems and structures also have embedded within them biases that can perpetuate racism, homophobia, sexism, and other forms of discrimination. When these biases are left unchecked, then families, individuals, and communities are harmed. To achieve health equity, policy change then must be developed with these multiple lenses in mind to begin to eliminate avoidable injustices, inequities, and disparities. So that's the frame of setting up this report from CPEN. And so let's look at some of the evidence. California demographics. There are just over 38 million people in California. California is the most populous state in the nation. It is the 6th largest economy in the world. In the 1990s, there were 7.69 million Latinos, whereas today there are approximately 15 million. In California, we see that it's majority minority, with whites being 39.2% and communities of color, 61%. In addition, California is the home, the largest share of immigrants, both documented and undocumented. Most of these immigrants from Latin America, but an increasing number, larger share from Asian countries. Currently, the Asian Pacific Islander population represents 13% of the population. This is up from 9% in 1990. When we look at the population by age, we see that right now there's about 12.1% who are 65 and older in our population. By 2030, 1 in 5 Californians will be over the age of 65. Currently, whites are the majority of those over 65, but this will soon change. Because of the shift in aging by race and ethnicity, the current health system will need to change as well to accommodate a multilingual, multicultural population. Communities of color are the majority in California. The counties with the highest percent of communities of color are Imperial County. Imperial County, 9 in 10, 87% of Imperial County are from communities of color, largely Latino. So 9 in 10 people you would encounter in Imperial County are from communities of color. Los Angeles, our home here, has 73% of LA are from communities of color. Merced, 69% of Merced County are from communities of color. So if we think about, I'm just going to flip back here. So commit this map in your mind right now of where the shading is, where the darker orange shade is where you have 61 to 87% communities of color. When we juxtapose that with income. In this chart, it presents the combination of high percent communities of color and low medium household incomes, the darkest blue here, to the lightest is the low percent communities of color and high medium household income. And what we see is it's a very similar tracking of where most of the communities of color are the places where we have the large proportion of low median household income. In some counties, communities of color face stark differences in earnings. For example, in San Francisco County, African Americans face the widest income disparities in earnings, 71 cents less for every $1 of white households, 71 cents less. In Sierra County, just here, in Sierra County, African Latinos fare worse in this county, 62 cents less, and American Indian Alaska Natives, 81 cents less. So we have wide disparities across different counties. The wage gap can be even larger for women of color. Among California's women who hold full-time year-round jobs, African American women are paid 63 cents, Latinos are paid 43 cents less, and Asian women are paid 72 cents for every dollar paid to white women. Unemployment rates are highest among communities of color who are more likely to live below the federal poverty line. In terms of economic status, we see unemployment is highest among African American men and Native American men and African American women. In looking at the proportion by race ethnicity of those who have incomes below the poverty level, we have higher proportions of Latinos and high proportions of African Americans and Native Americans. Unemployment disparities and wage gaps lead to further income inequalities that can limit access to educational opportunities, which means that some communities, families and children will be stuck in poverty. Housing status. Research has shown a connection between home ownership and overall well-being. Affordable housing actually is the #1 public health problem in Los Angeles County. Whites are more likely to own their homes compared to other communities of color. Affordable housing means that you are paying less than 30% of your total income. Many families, especially low-income families, pay more than 50% of their incomes on housing. This leaves fewer resources for food and for health care. Quality housing is also important to health, especially if the condition of housing or multi-unit housing units for low-income communities exposes them to secondhand smoke, to lead, to mold, to pest infestations. These exposures can lead to asthma and other respiratory conditions. Food access. And what I'm showing you is just, this is just a sampling of many of the indicators here in this report. So for food access, access to healthy and affordable food limits choices for healthy living. We know this. Limited food choices can lead to being overweight and obese. Communities of color have higher rates of overweight, obesity based on BMI. So for food access, for fresh food affordability, higher proportions of Latino, African American, and Native American report that fresh food is not affordable. Higher proportions of Latino, African American, and Native American compared to whites report that they have difficulty accessing any kind of healthy food. Green space. 86% of teens had access to parks, so I think that that's the semi-good news. But you see that there's patchiness in this access to green space. Surprisingly for me, when I first read this report, rural areas had lower access than urban areas. African American teens are more likely to report parks are unsafe during the day, so access isn't the only issue. Even if you have green space, is it a safe green space to go to? And teens of color report lower rates of physical activity even with close proximity to parks. Now we get to healthcare. Communities of color often have no usual source of care and are more likely to report difficulties in scheduling appointments within 2 days. While the ACA has expanded coverage to Californians, there's still the issue of barriers to care. Many still report difficulties in scheduling appointments, least likely to have medical home, and also are still least likely to have a usual source of care. And we see that particularly among Latinos, among Pacific Islanders, Asians, African Americans, higher proportions compared to whites who report not having a usual source of care. The difficulty in appointments within 2 days, those who report difficulty always, you do see higher proportions among Latinos. Self-reported health status. Self-reported health status or perceived health is an important indicator of overall health. It often correlates to disease burden. Communities of color tend to have a higher rate of diabetes, which is related to other indicators, such as access to healthy and affordable food, access to green space, physical activity, having a usual source of care, and the ability to schedule timely appointments. We see here higher proportions who report fair poor health among Native Americans and Latinos, and higher proportions diagnosed with diabetes among Latinos, African Americans, Asians, and Native Americans compared to whites. So now that I wished you joy over Thanksgiving and I just showed this report card of sadness, I think what I get asked a lot in my work in disparities research is, we're always talking about the problem. We're always talking about the disparities. But not so much in terms of the fixes. And why I showed you the social determinants of health slide and the definitions in the beginning is that a lot of these structural inequities that are wider than our health system, a lot of these are produced by policies. And so in combating racial ethnic disparities in health and health care, then the policies then have to be formulated in a way, again with this lens of thinking of intersectionalities, thinking of connections, thinking of interagency collaborations. And so all of the sadness that we see in this report of California being the 6th largest economy in the world, where you see maps of where communities of color live, work, play, where you see it in the agricultural areas, in the urban areas that fuel this economy to be the 6th largest. And you think then investment in these communities is actually investing in all of our communities in California. So, and now I can thank again, CPEN for going through a series of policies that have tried to fix these inequities. And this, again, is just a sample. But I think it's a way of moving the needle from continuing every year to report a sad report card disparities, but to look at then ways to try to address it. And these policies that I'm highlighting try to get at these intersectionalities, again with the hope and the frame that looking at these structural inequities that are not just in the health system, that this may be a way out to getting us to health equity. So, economic justice. We saw the charts of median income being lower for racial ethnic groups, minority groups, higher unemployment. And so in 2013, California passed a landmark bill to extend overtime protections for domestic workers. This is an important bill, so getting at social policies and social protection is an important ingredient in eliminating disparities, especially since the majority of domestic workers are workers of color. And so this particular bill gets at workers of color who had previously been excluded from these protections. Under these laws, these workers include child care providers, house cleaners, personal attendants who care for children, and senior people with disabilities. Now they qualify for overtime pay. So I think that this is one win in trying to get at some of these disparities. In 2014, California became a national leader by requiring employers to provide paid sick leave. This requires employers to give part and full-time workers, it's not just full-time workers, but at least 3 paid days of sick leave each year. How this is going to translate into better or worse health or eliminate disparities is still up for evaluation. But again, here's some opportunities to see these policy levers that are occurring in our policy landscape. In 2016, California also became one of the first states to raise the minimum wage. Earlier, San Francisco had raised the minimum wage and some other counties, but now as a state, California raised the minimum wage. It's hotly debated whether this is good or bad. I have some work on this globally, but over the next, which actually shows it's good, but over the next years, rising to $15 an hour by 2022. Again, another structural inequity that could be addressed. Education justice. In 2012, California voters approved Prop 30, and 2016 recently, Prop 55. This is an income tax on the upper 1.5% in California, and this money goes to raising over $37 million of funding for, I call K to 14, it's K to 12 plus community college, and now with this addition in Prop 55 with Medi-Cal. And a specific way to raise revenue for Medi-Cal, the program for low income in the state. In 2013, the local control funding formula became a national model that provides more equitable school funding with local flexibility and greater community engagement. I believe I saw in one of the reports that California was ranked at the bottom in terms of education. And a lot of it was due to Prop 13, a 40-year rule that limited then local control and also had limited dollars. So with this, then, it offers flexibility, it offers greater community engagement. But the other thing here that I thought was really important, and I'm seeing in the legislation that's coming out, is that there's this additional policy handle or mandate that supplemental grants will be based on the percent of English learners, low-income students, and foster youth. So in addition to having a base formula, then there's an additional grants if you are serving an underserved population. Environmental justice. I have colleagues that certainly know more about this, but I think the California Global Warming Solutions Act was committed California to reduce greenhouse gas by 2020. A major strategy is this cap and trade market system. It places a limit on emissions and a price on carbon, and this then generates revenue for a fund. Again, what's critical in this is then a later law by Senator De Leon imposed a minimum of at least 25% of this revenue to benefit disadvantaged communities. Again, I think that more and more the policies, and certainly the ones I'm highlighting, get at investing in disadvantaged communities as part of a California equity and growth strategy. In 2014, the Water Quality Supply and Infrastructure Improvement Act was passed. The water bond will provide funding on improving water systems, again, specifically in disadvantaged communities. And then how do we determine, though, which communities are the most disadvantaged? Who needs it most? Again, the health equity proposition is not that you give everybody the same thing, but you give what people need. And how then can you do that? Well, you can get it through better data. And the Cal Virus Screen data tool for identifying these communities is one such tool. Criminal justice. In the 2014-15 budget package, the governor and the legislators lifted the lifetime ban on receiving CalWORKs and the partial ban on CalFresh participation for people with felony drug convictions. To better facilitate the enrollment of jail inmates in public health insurance prior to release, AB 720 was passed. It complements the Affordable Care Act and California's expansion of Medi-Cal to low-income and childless adults. Again, very important in ensuring that the re-entry of former prisoners are supported with a safety net of health insurance. Healthcare justice. An 1115 waiver to implement the Whole Person Care pilot program. It's a demonstration project, and this demonstration project, counties are able to provide case management and care coordination to Medi-Cal beneficiaries who live with multiple and complex medical conditions. The focus is on individuals who do not have stable housing. Again, capturing this lens of connecting the dots on housing stability. And this is a provision of this focus, and those are frequent utilizers of emergency department services. The expansion of Medi-Cal to undocumented children through SB 75 Health for All Kids, again, is another example of getting at coverage for social determinants of health. Another example for healthcare justice. In 2015, a waiver program will fund a continuum of substance abuse services for Medi-Cal beneficiaries. Importantly, the counties can propose provider rates that allow them to maintain adequate networks that meet the linguistic and cultural needs of their communities. So again, another policy handle for counties to ensure that people have providers who speak their language and to understand their cultural needs. Counties can also create memorandums of understanding with county mental health plans. This incentive to integrate services to delineate responsibility for behavioral health screening and referral, and they must work with the criminal justice system to create these linkages. Again, another example of the healthcare system working outside of its sector. So finally, for Covered California, the state's health insurance marketplace, interesting, they're going to start tying financial incentives to year-over-year improvements in health disparities by race, ethnicity, and key target areas, including diabetes, hypertension, asthma, depression, this starting in 2017. I think this shows a commitment from Covered California that eliminating health disparities is an important part of their core values. But in order to accurately set benchmarks, Covered California also imposed an additional requirement on health plans to achieve at least 80% of self-reported race and ethnicity data from enrollees by 2019. This is absolutely important because with all the good intentions of trying to eliminate racial ethnic disparities, many times your data for tracking the services, you don't have race ethnicity in your data set. And so this important step of incentivizing that, that race ethnicity is reported is a critical step. Yes?
Thank you. These are wonderful programs. Could you comment on the adequacy of the state funding or funding from whatever source to help facilitate, fully facilitate the implementation of these various very good programs?
For this particular one, or for the ones that I've shown?
Some of the others.
A lot of this is a, I think this is the will of the Board of Covered California. Some of the other ones are based on revenue generation from a tax. So it's revenue financing from, that we voted in Proposition 30 to raise income tax, and then that of the top 1.5% earners in the population. And so the money comes from us voting that we will generate revenue and have a protective social protection system, because any social protection system is going to require a vote of the people that this is the cultural value, the social value that they want. We also, some of the environmental policies are based on a bond. Again, it's voters voting for that. So it's how this happens is that there also seems to be, I think, in California, a shift in the appetite to raise funds for more social protection.
Thank you.
So thank you for that question, because I think that that's a key part of how we can do the fix. To have the fix, you need to have the revenue to implement that. So I end with data because I think that some of these new laws are very exciting. And I think they're very exciting because they're bold in that they are moving forward again in looking at many factors that produce health inequities, that it's over and above the health care system. And I think it'll be a challenge, it'll be exciting to see if this approach is going to have more of an effect and have an impact on eliminating health disparities. But in order to do that, you need data. And so I end with data, the data sources and the caveats. This report was mostly drawn from data from the American Community Survey for the socio-demographic data. A lot of the data on health was from the California Health Interview Survey. Both data systems are continuously in the field. You have data every year, and so it's important to monitor progress 2 years down the line, 5 years down the line, 10 years down the line. Note that it's statewide and county statistics of health by race and ethnicity is really important to have. Also, social identities, sexual orientation, age, gender, national origin. It's really important to have the data. It is at the state level, and where possible, county level is reported. More and more counties, though, do want to have data because what I also described were more statewide policies. But there's also policies by community groups, by advocates that get at county level policies. I mean, the minimum wage in the state started in San Francisco. I believe Sonoma was one of the first counties to have smoking bans in multifamily apartment complexes. So a lot of the initiative and the action, the social movements happen locally, and we do need smaller geographic areas to monitor this. For those areas, we do invite you to look at the Advancement Project's California Healthy Cities site, and I have it here. Also, we have a tool here called Ask Just Neighborhood Edition, which provides indicators by a select number of indicators at the zip code level, city, legislative district. I also think that there's what I showed you in terms of racial ethnic disparities was the broad categories of race of Office of Management and Budget. So they may mask differences within the subgroups. And one group I know I've had a lot of experience with is the Asian Pacific Islander subgroups, where the aggregate category may be masking within group differences. And again, there's an appeal to have more data on by subgroups. And there was a recent bill by Rob Bonta that mandated more granularity in the Asian ethnic subgroups. So data is important, and I end with data just because it's so exciting. I'm actually so excited about this report that not just did it lay out all the disparities, that some of them persist and that continue, but that there's a way forward and that there seems to be a sense in California, I don't know nationally, but a sense of California that it's important to eliminate these disparities. And these examples that I showed were laws that were beyond the healthcare system, laws that got at criminal justice system, housing, laws that got at climate change, and so all very important. And also laws, in my observation, that had a specific handle, policy handle, that reserved funds and for ways to target disadvantaged communities. So the summary of this landscape of opportunity, another talk is, what is the landscape of opportunity? Well, the landscape of opportunity, in my mind, is the policies that that we can inspire, that we can inform, we can provide evidence to. There's no one single policy or solution that can eliminate racial ethnic health disparities, but I put forth these overarching principles by CPEN, and I think these are principles that many of my colleagues in public health would agree with. That the first is to create opportunities for an inclusive democracy. I think the lens of inclusivity is important when thinking of, again, making change, formulating policies. In that sense, organizations like CPEN has been very effective in terms of organizing, convening, and building coalitions on issues to translate the issues into broad policies that will benefit many communities. We want to analyze new and existing policies with this equity framework. Again, this notion of ensuring that communities of color, disadvantaged communities, are at the center of this equity framework, and that the systems that we look at are, again, beyond the healthcare systems. We want to improve data collection, analysis, and reporting. This was really important. It shows that without the data, we wouldn't be able to detect that there's a problem, and without the data, we won't be able to monitor if the solutions, if the policies that were introduced have any dent in solving these problems. We want to target resources to low-income communities of color. I think this is a basic principle that broad policies are important. A lot of these communities of color have to play catch-up. And by playing catch-up, then targeted resources are necessary. And you want to establish measures and processes for monitoring accountability. Again, the importance of data for accountability. So I wanted to thank you. Oh, we're almost there. So we wanted to thank you. This is the report, The Landscape of Opportunity. It can be found at cpen.org. I want to thank all the wonderful contributors of this work and for giving me the privilege of presenting this work to you.
Okay, so we're now going to do Q&A, and we usually do one question from the room, one from online, and so on and so forth, so everyone gets represented. So why don't we start with someone in the room? I think you have a question.
Could you go back a slide?
Sure.
Because on this and the previous slide you made the point of the last slide, data for major racial groups may mask differences of subgroups. No, go to your next slide, the next slide. Okay, these are excellent points. Target resources to low-income communities of color. Establish measures and processes for monitoring and accountability. Now, the people in these very communities you want to target, it is probably not as likely that they're going to have people trained in data collection and analysis so they can really share with other members of their community. So this leads me to really the tough question. Is the organization doing anything? Does this cost money and training? Or maybe finding young people, providing them with scholarships so that to raise the level of the subtle comprehension. I mean, you presented much good information, but it assumes a considerable background, or more than average background, in understanding and comprehending, working with, and to be able to share it with others as you're doing with us today. Now, related to this, how are the various subgroups interacting and understanding, and are they getting along? I mean, at the very beginning, you gave us information how various groups work together to get new legislation. Are they continuing to work together? And this question really relates, are there within the various groups individuals who really comprehend and understand this and can interrelate and share it with others in their group?
So if you can summarize the question, repeat it for the benefit of our online listeners.
I think the main point is that the data has to be...
If you could just repeat the question so that people know what was asked.
Right, so he's asking that if the training is important, because the data I presented today may be easily consumed by an audience like you here, but it's important to have the training and the presentation of the data so that it is understandable in these various communities. I think that was your first question. And then the second is, are we all still getting along? I think that's the second question is that if this framework of inclusive democracy and engaging with many other diverse communities, some of them with shared interests. For example, the Asian community, Latino community have shared interests in immigrant rights because both have large shares of immigrants in their population. That perhaps, are they still getting along, I think is your main question. And is this model sustainable? I'm adding that to your question. So I'll take the easier one. For the data to be well consumed across communities that may not be used to seeing all these charts that I showed, that I think that there's the California Pan-Ethnic Health Network works with many organizational leaders where there's a very broad-based active dissemination of the work. I can say that for the Center for Health Policy Research, the data that we produce, we try our mightiest to make it fresh and accessible, easy to use as possible, and understandable for a wide variety of audiences, because data is no good if nobody uses it. I think the data does have to be used and understandable to inspire social movements and collaborations and coalitions. And I think that's one role, the coalition building, that the California Pan-Ethnic Health Network provides. So I think that that's So I agree, and there should be training, and there should be engagement. The other is that data has to be used and shown to have an impact for people to believe that the data matters. I think your other question is do we all still get along together, or do communities still get along? I was so happy to be part of CPEN's 30th anniversary, I think, or is it 25th anniversary? I'm going to give them another 5 years. But they've had very long-standing collaboration, engagement, convening, and I think that the model seems to work. They've been around for over 25 years, and a lot of the bills that I showed to this audience here had CPEN and other organizations like CPEN who believe in coalitions that were the ones who inspired the bill writing. So I think that the model works, and the model, not only does it work, the model has to work even more now because we're just becoming more and more diverse. And in terms of, we're becoming more diverse and more intersectional. Again, this notion that it's not just that you're a person of color, but you're a person of color who's a woman, you're a person of color who's a lesbian, you're a person of color with a disability. So I think just having that intersectionality lens is really important. And we're just becoming more diverse. The fastest growing racial ethnic group in the United States, I have to check in California, so I have to fact check this, is the multiracial population.
So to our online questions, we have a question asking, do you have any recommendations for the granular collection of Asian data?
Do I have any, sorry?
Recommendations.
Recommendations. Well, I do. Okay, but maybe you should email me. So I do. The question is, do you have any recommendations for the granular collection of Asian data? Is that right?
Yeah, and if it's, we can always refer folks to our methodologies.
Yeah, I think you want to, there's always going to be a trade-off between, cost of collection, confidentiality, and collecting, several subgroups where the sample sizes may be too small. So you're going to have a confidentiality trade-off. But I think you should have goals. I think you should have standards. And the main goal is that you collect data as granular enough that reflects the culture of the communities that you serve. So if having an Asian aggregate category is not going to be of service to a group that wants to improve the health of the Cambodian community in Long Beach, for example, because the Asian aggregate statistics are going to look much better than the granular statistics in terms of health, educational attainment, a lot of the social demographics for the Cambodian community. So in terms of the model, I would suggest there is, I actually worked on this panel, Institute of Medicine, now National Academy of Sciences, has a report on standardization of collecting race ethnicity. So I think the other part with granularity is you want to collect it similarly as other groups and entities so that you can compare your education statistics with your health statistics. And you want to be able to roll it up. You want to be able, because at some point you're going to end up looking at aggregate categories, so you want to make sure that the roll-up rules are the same. So I think that report, and you can email me and I can send you the link to that report, is important. And I just also wanted to do a shout out to AB 1726, or the AHEAD Act, which was introduced by Assemblyman Rob Bonta. And so the data collection there is based on the national census, the different subgroups.
I don't mean to jump the queue for folks in the room, but there is an online question that feeds naturally into this, which is there a framework or can one be established to allow a continuity across all collection models and results?
Again, I think the Institute of Medicine report, I think, helps with that framework. It still starts with the OMB standards of the groups, and the OMB standards are being considered to be revised, by the way. But if, I can give you more, people are saying that's a great question. Repeat the question. Can you repeat the question? Is there a framework?
Or could one be established to allow a continuity across all collection models and results?
I think, again, this framework from the IOM report is a start. I think the census is, whether we like it or not, it's going to be our denominator for a lot of our health estimates. And so looking at the model for the census would be important. Luckily, it is pretty granular. Could be better, but it's.
So is there a question in the room?
Ying Yang, one of the study authors.
Big question. What you foresee the impact of this new administration at a federal government?
Which new administration? For California? For no.
All the policies and the regulations. I know California has the authority.
Well, I should say that a lot of the policies I showed has a kind of like a if our economy tanks. Oh, I'm sorry. So Ying Meng, one of the study authors who's here, asked, what do I see the impact of the new administration? Oh, the new administration and those policies.
Yeah, on those California specific.
Well, like Prop 50, California also has this, very, citizen-driven policies and laws. So we voted to continue this tax till I think 2020. So we have some time for some things. I think in many of the policies, there's if the economy tanks, that there's the governor can say we can't continue with this fund. So I think that's rational. I think in terms of California policies, I think the trend, especially with the recent elections, the trend seems to be very supportive and pro-social programs. So I think that's and pro-revenue generation, because we voted to have those social programs through either a tax, or the tax being income tax, or with the greenhouse gas emissions, it's taxing the polluters. So it's a supplier tax. So I think that there's, I'm hopeful that some of the policies are in place at least for the next 4 years.
Okay, just because we're over time, I'm going to end it there. But if you have questions, we will try and get them answered. You can email me. My email was up there, and I'll give it to you if you didn't note it down. But thank you very much.
Thank you. Oh, thanks.
Yeah, I hope that you're feeling them around California.
Yeah.
It's amazing.